Just a show of hands, who is reading prostate MRIs in the audience? Okay, so a lot of you. So hopefully I still managed to bring some new information because I'm trying to go through the basics and then to the more complicated. But hopefully everyone can get something from it. So again, as per usual, I'll start with the imaging techniques and then go over the PI-RADS version 2.1 in detail with lots of examples. Prostate cancer is the most common cancer in men, with incidence of 288,000 in the US. The lifetime risk of prostate cancer in men is as high as 13%. But luckily, the 5-year survival is excellent, with 97% survival. Therefore, most men who are diagnosed with prostate cancer are dying with the prostate cancer rather than the prostate cancer actually killing them. That's why the prostate cancer screening is still very controversial, and you have different organizations recommending different things. The USPSTF actually doesn't specifically recommend any screening for prostate cancer, but most other societies recommend some form of PSA screening, and the interval will depend on the initial PSA level and also the risk profile of the patients. In prostate cancer, once you're diagnosed, pathologically, it's defined by the Gleason score. So the Gleason score is actually made up of 2 numbers. The first number is the dominant pattern on pathology, and it starts as a minimum of 3 for cancer, goes up to 5. And then the second number is the second most common pattern on pathology. And they add the 2 numbers together, and that's how you get your Gleason score. More recently, there's a newer grouping with what's called a grade group, in which they reorganize the Gleason scores into these grade groups. And the rationale is that anything Gleason 7 and up, or grade group 2 and up, are considered clinically significant prostate cancers that need to be treated. Anything that's Gleason 6 or grade group 1 or below are considered clinically insignificant and don't warrant treatment right away, and those men can undergo active surveillance. So let's say you get a positive PSA screen. Historically, those men would undergo the systemic 12-core biopsy, but the problem with a random biopsy is that it can underestimate tumor grade in as much as 50% of the patient. So imagine you do this random biopsy and you get a report of Gleason 6, you go on your merry way, but we could have missed the higher grade tumor that would have put you into the treatment arm. So these days at our institution and a lot of other places, these men with a positive PSA will undergo the multiparametric MRI. And the reason is to try to increase the detection of those grade group 2 and above, the clinically significant prostate cancers. And if it's positive, the men would generally go through the MRI-guided biopsy of the target lesions, as well as the standard 12-core. We haven't done away with the standard 12-core yet, so the target biopsies are in addition to the standard. And if the MRI is negative, then they will undergo just a systematic 12-core. There are several prostate MRI clinical applications, including tumor detection or surveillance. I would say that's the primary referral for us. There's some indications for local regional staging, risk stratification, and the image guidance for biopsy and therapy, and to look at suspected recurrence. I would say for us, one of the big volume builders is really this MRI-guided fusion biopsy. So before this fusion biopsy, we would do a handful of prostate MRIs a week. And these days, we're doing a lot of them. Prostate MRI is easily about 10% of our body MRI volume, and it continues to grow. So after we read the case, we would go into this 3D program and then segment out the prostate and then label where the suspicious lesion is. And this step is important because in the past, I've done ultrasound MR fusion, but you do it kind of with your mind, and you really have to look at landmarks to be like, are you matching up everything in the right way? But what the urologist does, they really just rely on this. They're literally in there after they fuse the images, they are just aiming for the green, like they're not really looking at the anatomy. So this is a very essential step, and they really like it, and that's been helping us build our business. When we do the prostate MRI, it's getting proper history is important, and a lot of the times our urologists are very helpful in providing these because it helps us read the case better. We want to know the recent PSA level and the history, because honestly, if you tell me the PSA is 10, I may read that case a little bit differently if you tell me the PSA is 4. The date and the result of the recent biopsy and other relevant clinical history. If they had a recent biopsy that showed, say, maybe some Gleason 6 disease, and they just want to make sure on the MRI, we should wait at least 6 weeks for a lot of that inflammation to subside. Otherwise, it's going to make things very confusing. This is an MRI obtained after a recent biopsy, and you can tell on the T1 weighted images, there's abnormal high signal with the hemorrhage, and then it makes it very messy on the T2. So we should really wait at least 6 weeks. And in terms of patient preparation, we recommend that they get light meals the day before and the day of the exam. No caffeine or carbonated beverages 4 hours before the exam. If they have a morning appointment, we recommend that they do a fleet enema at home the night before. And then if they have an afternoon appointment, they should do the fleet enema the morning of. But regardless, we recommend the patient to use the restroom immediately before the exam to evacuate the bladder and the rectum. And we have really good technologists who are very experienced. So after they put the patient on the table, if they see a lot of the excess gas on the scout image, they would actually ask the patient to go to the bathroom again. Because there's no point in proceeding if there's a lot of gas in the way. That's just going to ruin your diffusion weighted images, and you have to call the patient back. What about 3T versus 1.5s? So these days, with the newer technology, both 1.5T and 3T can provide adequate and reliable diagnostic exams. The PI-RADS steering committee prefers 3T because obviously you can get better signal to noise, slightly better images, but in all honesty, 1.5, if you have a new system, works just as well. In fact, 1.5 is preferred for patients with implants that may result in artifact. And in our population, we see a lot of patients who come in with hip replacements, and those will automatically go to the 1.5. Just showing you some examples so we can get really nice quality images on the 1.5. This, I on purposely included the hip implant to show you that even on patients with implants, we can get nice images. This is the 3T. So with newer scanners, it's no issue. What about endorectal coil? So many years ago when I was a fellow, that was one of the jobs of the fellows, is to put in the endorectal coil. And when the technologists would come in, then we would all look very busy. So hopefully someone else gets to do it. But then we stopped doing endorectal coils many years ago because, again, with the newer systems, the image quality is quite good even without the coil. But if you are using an old machine, though, then you may need that endorectal coil just to get enough signal. And what about CAD? It's not required for multiparametric prostate MRI interpretation, but it may improve the workflow, and it can give you some quantitative data, may help with the lesion detection. But for us, the biggest motivation is really to help with that segmentation and the lesion contouring for diffusion biopsy. That's really our main purpose, not so much for the diagnostic aspect. In terms of our prostate MRI protocol, so you have small field of view, high-res T2s and axial and coronal, diffusion-weighted images, and DCE. And for our post-contrast images, we do big field of view through the pelvis because we want to catch any lymphadenopathy or bone lesions. Just to go through the sector map for the prostate, so it's divided into 3 parts. The bottom is the apex, and then mid, and base is actually at the top. And then it's divided into different areas. So the peripheral zone is actually the biggest part of the prostate, and that's where most of your cancers are. So the anterior aspect is the PZA for anterior. The more posterior part is divided into PZPL, the lateral, and also the PZPM for medial. And then the central zone is sandwiched between the peripheral zone and the transition zone. And it's usually just a very small part. And then you have the transition zone that's divided into anterior and posterior, so TZA and TCP. And as men ages, is usually you get a lot of BPH here, and it increases the volume of the prostate. And then the most anteriorly, you get a very thin band of anterior fibromuscular stroma. Just to show you how it goes from base to mid to apex. And one of the pitfalls that we have seen is people mistaking that normal anatomy in the central zone as pathology. So that central zone, you can see this ill-defined T2 dark signal that surrounds where the ejaculatory ducts come in, and it can look kind of mass-like, and people can mistake it for a lesion. I think it is helpful to appreciate the symmetry. So when you look at it on both axial and coronal, it's very symmetric. It also has that very characteristic fan-shaped morphology, so that those are very reassuring signs. But sometimes it looks kind of scary, like this case. Very dark, big lesions that are on both sides. But again, symmetry and then the shape, the characteristic location will help you know that it's just a normal central zone and you don't need to worry about it. In terms of the PI-RADS score, just like all the other RADs, has a 5-point scale, going from 1 with very low risk of clinically significant prostate cancer to 5 being very high risk of clinically significant prostate cancer. From a management perspective, lesions that are PI-RADS 1 and 2s will not get any biopsy. PI-RADS 4s and 5s should get biopsied. There's some question with the PI-RADS 3 whether or not they really need to be biopsied. At our institution, they all get biopsied. So basically all the 3, 4s, and 5s will get biopsy at our institution. Now let's go through bit by bit, starting with the T2 signal in the peripheral zone to go through that lexicon of what we're looking for. So score 1 in the PZ, you expect the uniform hyperintense signal. This is very rare in our screening population. I must say most of them, the people, when they come for screening, the peripheral zone is already a little bit messed up. So 1 is very rare. 2, we see these linear wedge-shaped hypointensities, or it may be more diffuse hypointensity, usually indistinct margins. 3, it gets a little bit more focal, heterogeneous, but still not very well circumscribed. This is like kind of like a smudge of hypointensity. And then when we get to 4, it becomes more circumscribed, homogeneous, moderate hypointensity. It looks like a focal mass when you get to 4. And also there's a size restriction. It's less than 1.5 centimeter. PI-RADS 5, same criteria as a 4, but it has to be greater than or equal to 1.5 centimeter, or it has definite aggressive behavior with extra prostatic extension or invasive behavior. I've also seen a lot of mistakes made with this size criteria, that some people will end up bumping what really is a PI-RADS 2 and a PI-RADS 3 up to a 5 on the basis of size. But you can only bump it if it already kind of started off as a 4, and then you can bump it to a 5. Otherwise, you can't just bump anything based on size. Now let's look at the transition zone. I think the transition zone is actually a lot trickier than the peripheral zone. So again, in the screening population, having a normal-looking TZ, this is, again, my one case that is a perfectly normal specimen. It's very rare. Usually we see some BPH nodules. Classic BPH nodules are very well circumscribed, T2 bright, and in the PI-RADS 2.1, if you see this typical nodule, you can put it as a PI-RADS 1. And then we like to joke about the ugly duckling sign when it comes to the transition zone. Because if you're trying to painstakingly look at the margins for every single nodule, you're never going to get through a case. But it's more like a gestalt, that do I have a nodule that is behaving differently from the rest of his friends? So that's usually the criteria that I use. So score 2 nodules are mostly encapsulated, homogeneous circumscribed nodule. It can be a homogeneous, mildly hypointense area between the nodules. Score 3, you get some heterogeneous signal intensity with some obscured margins. Score 4, you get lenticular or non-circumscribed, homogeneous, hypointense, and there's a size restriction of less than 1.5 centimeter. And then a 5 would be a lesion that's greater than 1.5 centimeter or has aggressive behavior. Next, let's talk about DWI. So we generate the ADC map from 2 or more B values. At our institution, we use 50 as our low and then 800 for our high. In addition, we also calculate a high B value of 1400. You can either acquire it directly or calculate it. We choose to calculate it because there's less artifacts. And if you use an ADC threshold of 750 to 900, that may assist the differentiation between benign and malignant prostate tissues. And we report that in our structure reporting, and I think that helps me to figure out, is it something that I need to worry about and actually score it, or is it fall into one of those more benign lesion categories that I don't really need to talk about it? Luckily, the rules for DWI is the same for the peripheral zone and the TZ. So score 1 is no abnormality on the ADC or the high B value. Score 2, we get these linear wedge-shaped hypointensity on the ADC or on the high B value DWI. Score 3, you can have some mild hypointensity on the ADC or some focal hyperintensity on the high B value. And then it's a little bit subjective what's just, mildly hypointense versus markedly hypointense. But the rule says that on the ADC, it cannot be markedly hypointense and markedly hyperintense on the high value DWI. And the reason is that blood or fibrosis would be dark on both DWI and ADC, whereas cancer would be bright on the DWI and dark on the ADC, and that is the distinction. PI-RADS 4, you get to have focal markedly hypointense on the ADC or markedly hyperintense on the high value DWI, less than 1.5 centimeter. And then a 5 is the same as a 4, but bigger, or has definite extraprostatic extension or invasive behavior. With the DCE is relatively straightforward, is either positive or negative. Negative is no early or contemporaneous enhancement, or a lot of the times the prostate can diffusely enhance, but that doesn't really correspond to any focal finding. And then for the positive, you have focal abnormal enhancement that's earlier than or contemporaneously with the enhancement of the adjacent prostate. And that abnormal enhancement corresponds to a suspicious finding on the T2 and or the DWI. And putting everything together, let's look at lesions on the peripheral zone. The assessment of the peripheral zone is really driven by how it looks on the DWI. The T2, it can honestly look like anything because it doesn't really contribute. The DCE only matters as a tiebreaker to bump something from a 3 to a 4 if it's DCE positive. These are examples of PI-RADS 1. So again, that pristine prostate, that one case that I have, with a clean on DWI. And the whole thing is enhancing, but there's nothing focal about it. So it's a PI-RADS 1. This other example, on the T2, we see that linear or wedge-shaped hypointensity, some very mild DWI on the restricted diffusion, no focal. Again, the whole prostate is lighting up, but there's nothing focal about it, so it's DCE minus. So this is a PI-RADS 2. This case, the whole peripheral zone is very dark with diffusely abnormal signal. So that would be a 2 on the T2. Again, not really any restricted diffusion, just little low signal here and there, but not that impressive. And then negative on the DCE, so again, it's a PI-RADS 2 lesion. This one, you can have some smudgy area on the T2, so I would give that a 3. And then you have some mild low signal on the ADC. This is the high B value. You have some high signal, so it's not really that markedly hypointense. The degree is not that strong. It's just kind of like mild signal. So I would give this a 3. And then the DCE as minus, so this stays as a 3. If the DCE was positive, then it would bump it to a 4. And on this one, you have some diffuse heterogeneous signal on the T2, on the T2 weighted images, some mild diffusion restriction, and DCE minus. So again, another example of PI-RADS 3. Now this is getting more suspicious looking, more focal, moderately hypointense on the T2, some restricted diffusion, and some signal on the high B value images with some DCE positive. You have to trust me because the whole prostate is enhancing. And on that note, a lot of the times I do like to look at the source images rather than the color map to really tell if something is enhancing earlier or brighter than the background prostate in the cases where the whole thing is lighting up like a Christmas tree. But regardless, so this will be a PI-RADS 4 lesion. Another example of PI-RADS 4, in which you have moderately T2 hypointense lesion, dark on ADC, bright on the high B value, and this is what I mean by looking back at the source images, so you can tell that that's a PI-RADS 4. Now things are getting bigger and more exciting, and then we have this very big infiltrative lesion on the T2, low on the ADC, high signal on the high B value, and then positive on the DCE. And this is an aggressive looking lesion crossing both the peripheral zone and the transition zone. So that's kind of the aggressive behavior that you need to worry about. And also based on size, that's what makes it a PI-RADS 5. And this lesion, similar scenario in which you have low signal on the T2, restricted diffusion, and enhancement. But it's also important to note that it's involving the urethral sphincter. It's important to mention that so that when the urologist does the prostatectomy, they have to be careful with that margin, because otherwise that may be the site of tumor recurrence in the future. And then this case is also a PI-RADS 5, but trying to illustrate the extraprostatic extension. So this is, again, why high-quality images is important. So you can appreciate the dark line with the prostate capsule, and then you have this mass that's interrupting that capsule. So that is clear extraprostatic extension. You can appreciate that on the axial and also on the coronal. You see the prostate capsule coming down, and then you don't see it anymore. So this is extraprostatic extension, PI-RADS 5. Just magged up so that you can see it better, how it interrupts the prostate capsule. And this one has extraprostatic extension into the seminal vesicle. So as we look, so a lot of the times it's important to pay attention to the symmetry of the seminal vesicles. If you see that the signal is very asymmetric, take a close look at the base to see if there's some tumor there. So we see abnormal dark signal going up the left seminal vesicle. That area has restricted diffusion, abnormal contrast enhancement, so another PI-RADS 5. And then this shows the involvement of the neurovascular bundles. So the neurovascular bundles are these little dots that travel along the posterior lateral aspect of the prostate. Again, high quality images is key. And on the left side, you can see that this abnormal tumor that's breaking through the capsule and also touching these little dots, which are the neurovascular bundles. Obviously, restricted diffusion, abnormal enhancement. So again, another PI-RADS 5 lesion, just magging up so that you can appreciate that. So with the transition zone, it's the opposite. It's the T2 that matters. The DWI functions as a tiebreaker that can upgrade some lesions from a 2 to a 3, or some lesions from a 3 to a 4. So again, my one example of really pretty PI-RADS 1, really pristine looking transition zone with no nodules, but you are allowed to have classic looking BPH nodules in PI-RADS 1. Yeah, this is what I mean. A lot of the times you get prostate that look more like this. So then the challenge becomes to pick out the nodule that really looks different from everyone else. As long as everything kind of looks like everything else, I let it go. Because otherwise you're going to call a lesion on everybody in the transition zone. And on this lesion, you can say the whole prostate is a little bit, heterogeneous. But what really caught my attention on this case, frankly, was the diffusion. The diffusion on this nodule is focal diffusion restriction, as opposed to the rest of the transition zone. So that's, to me, that's how the kind of tiebreaker comes in. Another example here, so nodule. I pay a lot of attention when it's kind of straddling the different compartments. So this one is a TZ lesion, but it's also growing out into the peripheral zone. So to me, that is an aggressive behavior, plus the focal diffusion restriction and DCE positive. So that also would bump it to a PI-RADS 4 lesion. This is a 5 on the basis of both size and aggressive nature. Again, in that location where it's straddling the boundary between the transition zone and the peripheral zone with the restricted diffusion and everything, making it a PI-RADS 5. Another lesion, more of the same, but basically I really wanted to show you all these examples to contrast, the usual kind of BPH versus confirmed prostate cancer. So really aggressive looking ill-defined margins with the restricted diffusion. So what if you don't have an adequate DWI? Then you are really relying on your T2s with some DC at that tiebreaker level, bumping from a 3 to a 4. And what if you don't have adequate DCE? That's actually not so bad, because now some groups are advocating biparametric MRI that actually relies on the DWI and T2 and don't actually inject contrast. So the peripheral zone, you're relying on the DWI, and in the transition zone, you're looking at the combination of both the T2 and the DWI. And there are lots of other things that are on the horizon. We also report the PRECISE score. I'm not going to go into detail, but basically now we have a lot of men who have serial comparison exams. So the PRECISE kind of allows you to compare the current one with the previous one. Are things looking stable, better, or worse? So that also helps you. And also quality imaging is important. There's a lot of discussion about a PI-QUEL score for quality, so that we basically put a qualifier on how confident are you about the prostate MRI, because how good your interpretation is contingent on the quality that it was done of the exam. In conclusion, multiparametric MRI is commonly used for prostate cancer screening and cancer staging. And the PI-RADS 2.1 provides detailed guidelines for image acquisition and interpretation. And that high-quality technique is really critical for accurate interpretation. And it's also really important to implement a quality assurance program to ensure consistency. I would say the only way to get better at prostate MRI is really to get feedback. We recently implemented a system in Epic in which it pulls out reports with the pathology so that the radiologist can really learn from that feedback. And I think if you're going to read prostate MRI on a high volume basis, having that kind of feedback mechanism is critically important. And thank you very much.